excruciating paroxysmal pain in the lips, gums, and cheek and chin region. This is mainly supplied by the trigeminal nerve. The pain usually lasts for a few seconds to minutes, and it may occur either spontaneously or after some particular movement like chewing or speaking or smiling. During that time, it can happen. What is the drug of choice for trigeminal neuralgia? Carbamazepine. Carbamazepine is a drug of choice for trigeminal neuralgia. Then what is glossopharyngeal neuralgia? Glossopharyngeal neuralgia is mainly because of the glossopharyngeal nerve and sometimes the vagus. It is an intense paroxysmal pain that originates from the sides of throat or the palate near the tonsilla fossa. This pain may get aggravated during or initiated after swallowing or coughing. The glossopharyngeal neuralgia sometimes has cardiac symptoms. And those symptoms include bradycardia, hypotension, and fainting. The treatment of choice for glossopharyngeal neuralgia is also carbamazepine. Right? Then what is geniculate neuralgia? It is basically the paroxysmal pain that is starting in the ear. Right? Then Schluter's neuralgia. Schluter's neuralgia or the anterior ethmoid syndrome. Schluter's neuralgia or the anterior ethmoid syndrome. This is the pain that is present in the base of the nasal bridge, often radiating to the forehead. The treatment of Schluter's neuralgia is mostly surgical. Then, what is the most common cranial nerve that is involved in leprosy? Answer, please. What is the most common cranial nerve that is involved in leprosy?
7, ma'am.
Yes, the facial nerve. What is the most common cranial nerve that is involved in herpes zoster? Answer, trigeminal nerve. This is the most common cranial nerve involved in herpes zoster. Smallest cranial nerve, answer. First, tell me, we'll finish off the medicine first. The smallest cranial nerve. What is the smallest cranial nerve? Yes, longest cranial nerve.
There is no.
Largest cranial nerve.
Trigeminal.
Cranial nerve which gets involved in an increased ICP. Cranial nerve to get involved in increased ICP. Abduction nerve, okay. Cranial nerve with the longest interosseous root. Cranial nerve with the longest interosseous course is the facial nerve. Right? Then CNS hemorrhage. In CNS hemorrhage, you have subarachnoid hemorrhage, you have to know about it, and the intracerebral hemorrhage. Subarachnoid hemorrhage, what is the most important MCQs in subarachnoid hemorrhage? What is the most common cause of death? In a subarachnoid membrane, it is vasospasm. Okay. In case of an acute SAH, the investigation of choice would be non-contrast computed tomography. In a chronic SAH, the investigation of choice would be a gradient echo MRI. Then in intracerebral hemorrhage, most common cause of intracerebral hemorrhage is hypertension. What is the most common location of intracerebral hemorrhage? It is the putamen. Right, these are the basic MCQs that we have to know in the CNS hemorrhages. Then coming to some few degenerative disorders like Wilson's disease. I already discussed about Wilson's disease in in pathology. So in the few points that we missed in pathology is the MRI brain sign. In MRI brain, you'll have face of panda appearance. You have face of panda appearance. And also, in the eyes, there will be KF ring, Fleischner's ring. KF Fleischner's ring. It is basically the deposit of copper in the resonance membrane extending into the trabecular meshwork. So KF rings will be present. These are the few points that is extra to the one which we discussed the other day in pathology. Then Parkinsonism. The problem with Parkinsonism is decreased dopamine secretion from the brain. And if you see the pathology, you'll see Lewy bodies. The most common place affected in the Parkinsonism in the brain is the substantia nigra. Right? What is the most the chromosomal defect is chromosomal 1 defect. Clinical features, you have resting tremors, rigidity, chestinating right, bradykinesia, slow movement, bradykinesia. These things are all the clinical features of Parkinsonism, and the drug of choice is pramipexole or ropinirole. Okay, this is what you have to know in Parkinson's for the examination. Then coming to Alzheimer's disease. In Alzheimer's disease, the problem is decreased acetylcholine in the brain. What bodies will be seen in pathology? Hirona bodies will be present in the pathological specimen. What is the most common place to be affected? It is the nucleus of Maynard. The chromosome that could be affected is either 1 or 14 or 21 or 22. Right? What is the clinical feature? Alzheimer's disease usually presents with amnesia. Right? Apraxia, abnormal movements, apraxia, agnosia, inability to judge things. Then acalculia. Right? Then the drug of choice for Alzheimer's is donepezil. Donepezil is the drug of choice for Alzheimer's disease. The next disease that you have to know is the multiple sclerosis. Multiple sclerosis, it is basically an autoimmune disorder that attacks the immune system, myelin sheath. that attacks the myelin sheath in the central nervous system. It usually affects young women of 12 to 20 years, 20 to 40 years of age. What is a triad of multiple sclerosis? Inflammation will be there. Because of autoantibodies acting against the myelin sheaths, you will have demyelination along with gliosis. Right? Then MRI. MRI will have features of Dawson's fingers. Right? CSF analysis usually will show mononuclear phagocytosis and a raised IgG levels in the body. The most common symptom that will happen is all mostly sensory loss. How do we treat it? Acute attacks are usually resolved by steroids. Acute attacks are usually resolved by IV methylprednisolone. Whereas to reduce the recurrence and exaggerations, to reduce this, interferon beta is given. For slowing the progression of disability, cyclophosphamide is used. Then among the monoclonal antibodies, the one which halts the expanded disability status score. The one which halts this score is the monoclonal antibody. Which is the monoclonal antibody which is used for multiple sclerosis? Answer. It is natalizumab. Right? It is an important MCQ that they can ask you in exam. Natalizumab is the one which halts the progression of the expanded disability status score. Right? Then migraine, different types of migraine. The classical migraine can be with aura. That is, the aura means, what is aura? Classical migraine with aura. Aura means you will have some sensory or a visual symptom that comes. Either when they have a headache, they'll have a photospectrum in the visual field, or they'll feel some smell or some abnormality in the visual, in the sensory part, they have it. This is all is called aura. Classical migraine is with aura. Whereas other without aura migraines will not have any neurological signs presenting with them. Then what is basilar migraine? Basilar migraine has predominant brainstem dysfunction like vertigo, dysarthria, diplopia. Facial migraine. Basically, the lower half of the face will have the pain, especially in the jaw region, neck region, all they will have pain, and also periorbital pain will be there, along with carotid tenderness. This is called facial migraine. Then focal migraine. Focal migraine will have migraine plus a transient dysphagia. A transient dysphagia along with a hemisensory loss. Right? All these things will contribute to the focal migraine. Then familial hemiplegic migraine. This is a migraine plus the failure to recover from the focal neurological symptoms. Right? Ophthalmoplegic migraine, of course, will involve the paralysis, partial paralysis of the third cranial nerve. Partial paralysis of third cranial nerve. That is the oculomotor. What is retinal migraine? Retinal migraine is a migraine along with the transient unilateral loss of vision. There is something called acephalic migraine. Acephalic migraine is basically a sensory or a motor loss migrating to the lower limb without headache. This is a myocephalic migraine is one without headache. Involves the sensory and motor loss migrating to the lower limb. These are the different types of migraines. When you ask me what is different types of headache, tension headache, everyone will know. It is a tight band like discomfort in the bilateral frontal area, and it is usually accompanied by the situation like intense feeling of grief or anxiety or depression. You have it, and this pain will be either throbbing or constant. And the recurrent attacks are common until your problem comes. And what is a sinus headache? It is because of the inflamed sinus, you have a deep constant pain in the cheekbone, forearm areas. And running nose, feeling of fullness in the ear, fever, swelling of the face is all because of the sinusitis. What is temporal arteritis? Temporal arteritis is a unilateral or bilateral, located mainly in the temporal region, associated with pain at jaw movement. And scalp tenderness will be there. Headache is worst at night. Sometimes there are high chances of having a sudden blindness due to an ischemic optic neuropathy. Ischemic optic neuropathy is a possibility if ophthalmic artery is involved in any of these patients with a temporal arteritis. Right? Then coming to TIA and stroke. What is TIA and what is stroke? Someone? What is TIA? After a cerebral ischemia, when the blood flow is rapidly restored, the brain will recover fully. Right? So the attack will recover. The clinical feature will last for maybe 5 to 15 minutes. Maybe up to less than 20 or 24 hours. If it goes beyond 24, if the symptom lasts beyond 24 hours, you call it as the stroke. Right? Usually, in a midbrain stroke, what is the most common artery affected? In a midbrain stroke, what is the most common artery that is affected? It is the proximal PCA, posterior cerebral artery. That is the one which is involved. In pontine stroke, which is the most common involved artery in a pontine stroke, it is the basilar artery. right? Then what is medullary stroke? The most common artery involved is the vertebral artery. Okay, this is what is regarding the important arteries and the stroke. Say the site of lesion is in the anterior cerebral artery. What will be the clinical presentation? This patient will usually present with contralateral hemiparesis plus a sensory loss, right? If it's a middle cerebral artery means it's a major stroke. If the superior part of the middle cerebral artery is involved, means you have a contralateral hemiparesis along with the sensory loss. Usually upper limb will have more weakness than the lower limb. Then you have expressive aphasia. Expressive aphasia. Inferior part of the MCA usually to have contralateral cortical sensory defect. Contralateral cortical sensory defect will be there. It is nothing but stereognosis. Say for example, if there is a one, when you're climbing down the step, the next step you are not able to analyze the at what depth the next step is there. The process of analyzing is stereognosis. If it's not there, probably contralateral stereognosis is because of inferior part of MCA involvement. Then contralateral homonymous hemianopia. Then acute confusion could be there. It is a very common symptom, acute confusion. Very common symptom. Then even special thought disorders could be there. Right? This is what MCA is very important. Whenever a stroke patient comes, just by in the initial analysis, without even taking a CT or a MRI, you will be, if you know this clinical content, you will be able to identify which artery is mainly involved in that. Then PCA, posterior cerebral artery. When PCA is involved, it's called as the Weber syndrome. This Weber syndrome has got ipsilateral oculomotor palsy, contralateral weakness, contralateral hemianopia, homonymous hemianopia with a macular scarring. Then visual agnosia and cortical blindness. You will be able to see, but the brain is not able to realize what is that. So that is what is regarding PCA. Then what is Lateral-Pontine syndrome? Whenever there is an anterior inferior cerebellar artery involvement, it is a lateral pontine syndrome. This will usually present as ipsilateral facial paralysis and deafness. Ipsilateral facial paralysis and deafness will be there. Along with that, you have something called as the other features of Wallenberg syndrome. What is this Wallenberg syndrome as such? Wallenberg syndrome is a posterior inferior cerebral artery involvement. During that time, the patient will have ipsilateral Horner syndrome, ipsilateral dysphagia, ipsilateral facial numbness, right? Then contralateral sensory loss in the limbs. Then ataxia, nystagmus. Right? This is what is the Wallenberg syndrome. Wallenberg syndrome is otherwise called as the lateral medullary syndrome. Right? Then coming to this locked-in syndrome. What is locked-in syndrome? This is mainly because of the basilar artery involvement. Right? Then the bacillary artery involved, sorry, basilar, not bacillary, it's basilar. The patient will have quadriplegia, aphonia, and horizontal nystagmus. Right? Such patients are called as the locked-in syndrome, or it's otherwise called as the pseudocoma. Right? Then what is amaurosis fugax? Amaurosis fugax. This is mainly because of the ophthalmic or the retinal artery involvement. This is a transient mono-ocular blindness. This is a transient mono-ocular blindness and usually presents with fogging of the visual field. Fogging of the visual field. Right? Then Fontaine lesion. Fontaine lesions, usually they have a rapidly deteriorating consciousness. Rapidly deteriorating consciousness along with diplopia, extensive sensory motor defect. Extensive sensory motor defects with an ipsilateral cranial nerve 6-7 palsy, contralateral hemiplegia, pinpoint pupils. But this is a very important sign. Whenever there is a pinpoint pupil, there is an involvement of P for P, Fontaine, right? You remember that, and the patient will have a decerebrate posture. Right? This is what is regarding the lesions in the stroke, I mean the ones which is involved in stroke. If you say those same vascular lesions but affecting the spinal cord, you will say it as an anterior spinal artery occlusion. Anterior spinal artery occlusion, the tracts, if it is involved, is the lateral spinothalamic tract. What will be affected? Spinothalamic means it's always pain and temperature. If it's lateral means both. Because spinothalamic has both in ipsilateral as well as contralateral fibers. Both the fibers will be there. So bilateral pain and temperature loss. If the lateral corticospinal tract is involved, it is basically movement. Corticospinal is the muscles, right? So when that is involved, it will cause bilateral spastic paresis. Then what is Brown-Sequard syndrome? Brown-Sequard syndrome. Brown-Sequard syndrome, lateral spinothalamic tract. It is a, whenever that is involved, you lead to contralateral pain and temperature loss. In Brown-Sequard, when the lateral corticospinal tract is involved, they'll have an ipsilateral spastic paresis below that lesion. When the dorsal column is involved, it is ipsilateral, loss of proprioception, and vibratory sense. Ipsilateral loss of proprioception and vibratory sense. The other important thing with the spinal cord lesion is the subacute combined degenerative disorder. Subacute combined degenerative disorder. When it involves the lateral corticospinal tract, it causes bilateral spastic paresis. When it involves the dorsal column, it is bilateral loss of proprioception, and what else? Dorsal column deals with vibratory sense also. Vibratory sense is also lost. Then spinocerebellar tract. Spinocerebellar tract, bilateral limb ataxia. Bilateral limb ataxia. Then what else? That's all is regarding the lesions in the spinal cord. Then in neurology, you have to know a few things like the Bell's palsy. Bell's palsy is the most common palsy that a person can have. It is mainly because of the idiopathic facial paralysis. Association with herpes simplex virus is also there. So prednisolone gives a faster recovery. Then what is Creutzfeldt-Jakob disease? Creutzfeldt-Jakob disease is basically a degenerative disorder of central nervous system. It's caused by the prions, proteinaceous material, prion. It leads to impaired judgment. It leads to impaired judgment and decline in the intellectual functions. Diagnosis is basically by the MRI, where you have a spongiform degeneration, right? Then myasthenia gravis, it's a big topic. It's a neuromuscular disorder caused by the autoantibodies to the acetylcholine receptors, right? So it causes weakness and the fatigability of the skeletal muscles. So what we do, we usually treat with acetylcholinesterase inhibitors. When esterases are not there, more acetylcholine will be there. And if more acetylcholine is there, then it will go fight with the autoantibodies and act on the particular receptor, thereby causing the action. Then the any damage with caudate nucleus will present as chorea to the patient. Any damage with globus pallidus will present as athetosis. Then any damage with the subthalamic nucleus it will present as the hemibalismus. These are the possible MCQs that can come for you. Okay, so this is what is regarding neurology. We'll take a 5 minutes break and continue with cardiovascular. Am I audible?
Yes, ma'am.
Okay, we'll start with CVS. In CVS, you have to know about few important things like the auscultation areas. This is the sternum. Where will you auscultate for the mitral valve? At the apex of the heart, right? The tricuspid valve usually at the left lower sternal border. If it's an aortic valve, it will be right side second intercostal space. This will be aortic valve. Left second intercostal space will be the pulmonic valve. So this is the place where you auscultate for the heart sounds. Then few heart sounds and murmurs that are important alone, I will tell you. Where will you see hemoplop? Hemoplop valve will be seen. It is usually seen in atrial myxoma. Where will you see pericardial knock? Pericardial knock will be seen in the constrictive pericarditis. Right? Then pansystolic murmur on the right side. Right side pansystolic murmur. Right pansystolic murmur will be usually seen in tricuspid regurgitation. Left side pansystolic murmur will be seen in chronic MR more than the ventricular septal defects. Where would you see continuous murmur? Continuous murmur, you see it in patent ductus arteriosus more than the AV fistulas. Right? Then coming to cardiac, you have to know about the anginas. Right? What is an angina? It's a central chest pain, either crushing or wheezing or heaviness. It radiates to the neck or a jaw or the left shoulder. And it could be associated with nausea, vomiting, dysphagia, pallor, and everything can be there. Types of angina: stable angina is where you have an fixed plug in the space, the coronary arteries, that will cause pain on exertion. And rest will relieve the pain. Rest or vasodilators like Grisolol, trying will relieve the pain. 1 minute. Okay. ST elevation or T wave inversion could be there in the. Am I audible?
Yes, ma'am.
Okay. In the ECG, and the treatment, if it has not progressed to an MI, then beta blocker. MI means MI treatment only. Right? Then unstable angina is the one where you have a plug that has ruptured. Pain occurs even at rest. And pain is not relieved by vasodilators. ECG will have either normal or a T-wave inversion pattern. And how do you treat it? You treat it with IV nitroglycerin. There is something called transmittal angina. What is that? Transmittal angina. It's an unstable angina. It mainly happens, the pathology is the coronary vasospasm. Coronary vasospasm. This has a pain at rest. And pain, it is getting relieved by glyceryl trinitrate, right? And ECG, it has got an ST elevation in the ECG pattern, and the treatment is IV nitroglycerin, right? Then ST elevated MI, here, of course, myocardial damage will happen, acute MI, ST elevation will be present, top I will be elevated. How do you treat it? First treatment, you give rest to the patient, oxygen to the patient. Second, you give some analgesics like morphine. Third, you give them antiplatelets. What all will you prefer? You give aspirin, 150 mg, then clopidogrel, 150 mg, stat, along with a statin, either atorvastatin or whatever statin you want to give. If it's atorvastatin, it's going to be 80 mg. You give them as a stat, and then the definitive therapy includes revascularization. How will you revascularize? You can either go for percutaneous coronary intervention, PTCA, or angioplasty, direct stent placement, or you can go for a thrombolysis to revascularize that particular area, or directly you can go for a coronary artery bypass graft. Right, this is STEMI. Then about NSTEMI, where you don't have an ST elevation that is obvious in the ECG, but the treatment is same. Then next thing which you have to know is the aortic dissection. This aortic dissection, this has happened because of the tear in the intimal layer. Because of the intimal tear, aorta is there, right? Yeah, this intima inside. Usually there will be a tear in the intima. So what happens? The blood gets collected in this area, becomes big like this. And will be an excruciating pain when the blood enters the tunica media. And this can happen suddenly. Sudden onset tearing or ripping type of pain can also be there. How you can identify by decreased pulsation in the peripheral arteries. Okay. This investigation of choice would be definitely angiography. Mostly CT angiography. And how do you treat it? Treatment, first line will be to control the blood pressure. Second, but the definitive treatment would be surgery. Okay, this is what is regarding the cardiac pain. Then coming to pleuritic chest pains, what are the causes of pleuritic chest pains? Pleuritic chest pain, the pain happens because of desinspiration associated with the dyspnea on exertion, right? And it is not relieved by nitrates because there is no role for nitrates here. One such condition is pneumonia. Pneumonia is actually infective where you have fever, chills, cough, dyspnea, tachycardia, all those symptoms of COVID, all those things will be there. Usually, how do you, the physical examination of pneumonia, there will be increased tactile fremitus. When you touch it, you will be able to see the fremitus on on palpation, dullness on percussion, in auscultation, you will have bronchial breath sounds, crepitation redux. Okay, this could be there. And how do you treat it? Of course, with oxygen. Second thing, antibiotic. If the person is smoking, ask them to stop smoking. Then tension pneumothorax. Tension pneumothorax is sudden onset of a pleuritic chest pain because lungs is there, chest is there, the air inside the lung goes here and it gets filled in the gets filled in this area and thereby produces a tension around that area. These patients will have a decreased chest wall movement, absent breath sound in that area, and how do you treat it? First one, give oxygen. Second thing, you have to, if it's an emergency tension perhaps pneumothorax, you go for a needle thoracotomy. After needle thoracotomy is just temporary decompression procedure. After that, you put a intercostal tube. Needle thoracotomy in the, say, in the left second intercostal space or the fourth intercostal space, in the mid-axillary vein, you put a needle so that the air comes out. That is temporary. Then after that, in the fourth intercostal space, in the mid-axillary region, you insert the ICD so that air inside comes out. This is thereby releasing the tension in pneumothorax. Right? Then pleural effusion. Collection of fluids in the pleural cavity, more fluid in the pleural cavity. This is also because of bacterial infections, could be a reason. Pain, patient will have fever, pain, dyspnea, all these things could be there, and there will be decreased breath sound in that particular area with the dullness on percussion. Right? The patient in the chest X-ray, they will have blunting of costophrenic angle. Blunting of costophrenic angle. And these patients, how do you treat it? You treat with oxygen, then diuretics, antibiotics if infective, and last it is thoracosynthesis. To drain the fluid from the pleural cavity. Then pulmonary embolism, it could be because of a deep vein thrombosis in some lower lung veins. These patients usually present as giddiness and with dyspnea. They can present like this. In clinical presentation, the patient will have a pleural frictional rub along with cyanosis, rales, tachypnea, tachycardia. Echo, you have right ventricular dilatation on echo. Treatment is basically anticoagulation and thrombolysis. Right? Then pericarditis. Pericarditis, it is a pain with dyspnea and low-grade fever. On clinical examination, this patient will have a frictional rub, tachycardia, pulsus paradoxus, and a distant heart sound. Of course, chest X-ray will show a cardiomegaly. And treatment is treat the cause of pericarditis. Second thing, pericardial drainage.
Yes, ma'am, audible.
Yes, ma'am.
Okay. So hypertrophic cardiomyopathy, it is the most common cause of death in a young athlete. The most common symptom that is usually present is dyspnea on exertion, and the genetic defect is
Ma'am,
the
screen
beta
matrix
myosin
is
gene
visible.
defect. No?
Yes, ma'am, visible.
Okay. So, and the chromosome that will be involved is the chromosome 11, and the treatment of choice for a hypertrophic cardiomyopathy is beta blockers. Then, few points about infective endocarditis. It is because of the vegetations in the valve area, right? The hallmark of infective endocarditis is the vegetations. And the other common things that is involved with this infective endocarditis is Geneva lesion, Osler's knot, splinter hemorrhage, right? And the most common complication is the cardiac failure. The most common sign of this infective endocarditis is fever. And of course, it's a septic emboli. And the most common valve that is involved will be which valve? Mitral valve. But in case of a person who's an IV drug user, most common valve in infective endocarditis in IV drug abuser is what? Is the tricuspid valve. Okay. So, and coming to the most common organisms that is involved in an acute bacterial endocarditis, which is the most common organism that is involved. That is Staph aureus and coagulase negative Staph aureus. Right, in subacute bacteria is Streptococcus viridans. Chronic infective endocarditis, it is TB or brucellosis, Bartonella, Treponema whippley. Okay. Community acquired in native valves. Community acquired in native valve is the Streptococcus viridans. Hospital acquired in native valves is the Staph aureus. Early prosthetic valve endocarditis. Early prosthetic valve, within less than 1 year, it is coagulase negative Staph aureus. Whereas late prosthetic valve, more than 1 year old, is the MRSA. How about the IV drug abusers? In IV drug abusers, if it's a right heart that is involved, the most common organism is Staph aureus. If it's the left heart that is involved, the most common organism is the enteropochyre. Right? Then, in case of a sterile culture negative bacterial endocarditis, sterile culture negative bacterial endocarditis, It is Treponema whippley. Okay, so this is what is regarding the organisms. In infectious endocarditis, you have to know about the criteria, that is the major and minor criteria of diagnosing. What is the name of this criteria? It is the modified Duke's criteria. What are the points that is involved in the, taken as the positive major diagnostic criteria? One is the positive culture. Positive culture for a typical infective endocarditis organisms. Okay, 2 separate cultures has to be taken, which is 12 hours apart. And usually you take this culture before the antibiotic. Second thing, in the echo, you have to see that oscillating intracardiac mass around the valves. Right? Third thing, either you will have a single positive culture for coxial aberrantity or the IgG antibody, antiphase IgG antibody has to be more than 1:800. These are all the major criteria. Minor criteria includes prior heart problem, prior cardiac conditions, temperature more than 100.4 Fahrenheit, any vascular phenomena like any thrombi, peripheral arterial thrombi, pulmonary infarct, myocardial aneurysm, any vascular phenomenon. Conjunctival hemorrhage, January's mention, all these things. Then immunological phenomenon like the glomerulonephritis, Osler's nodes, Roth spots, all immunological factors like rheumatoid factor. All these things are immunological phenomenon if this is present along with the microbiological evidence. Like a culture, positive culture, but it does not meet the major criteria like a culture taken 12 hours apart. If that criteria is all not met, then you take it as a minor criteria. So how do you diagnose infectious endocarditis? It is either 2 major which should be present or 1 major and 3 minor should be present or 5 minor should be present. In these criteria, you take this as an infective endocarditis. Next, this sort is regarding cardiac. Then is the respiratory system where you have asthma, bronchial asthma. What is the difference between bronchial asthma and COPD? Both are involving inflammation of the airway, but in case of an asthma, there will be, both are small airway disease, but in case of an asthma, there will be reversibility after this beta agonists. Reversibility of more than 12% in the PFT signifies it as a bronchial asthma. If it is not reversible, it is a chronic obstructive pulmonary disease. If it's bronchial asthma, how do you actually grade it? You grade it with the peak expiratory flow rate. How much percentage is reduced? Normally, it's around 80. So if it is mild asthma, means PFR will be more than 75%. If it's moderate asthma, PFR will be 50 to 75%. Severe asthma, it is 33 to 50%. These people will not be able to complete a sentence in a single breath. Tachycardia will be there, tachypnea will be there. Life-threatening asthma will be less than 33%, confused, comatose, exhausted. The saturation will be reduced less than 92. Bradycardia will be there, hypotension. It is a life-threatening condition where acute treatment has to be done. Okay. So whatever may be the asthma range, it has to be treated. Usually, you treat initially with a short-acting beta agonist. If it is not working out, then you add a short-acting beta agonist. Along with that, you add some low-dose inhaled steroids. If this is not working, you put a agonist, low-dose inhaled steroids. Along with it, you add some montelukast. If this is not caring for that, then you give a short-acting beta agonist along with a long-acting beta agonist, along with a low dose of steroid. Okay, this is also an inhaled dose of steroid along with montelukast. Right? If this is not acting, you give the steroid dose can be increased. So, if you try increasing all these things, if it is not at all working, the final one could be oral steroids and IV steroids. Tapering will also be in the reverse order. In case of a severe life-threatening asthma, mechanical ventilators, intubation and ventilating the patient could have a role. Asthma, if it's emergency treatment, we spoke about the long-term treatment. If it's acute and severe status asthmaticus, you give oxygen first. Second thing, you give nebulization salbutamol, Budicort nebulization, along with IV hydrocortisone. See, people think that whenever you give steroid problem, it gets solved. It's not like that. IV hydrocortisone, the steroids will have, where will it have the receptors? Whether the steroid receptors will be there in the cell or the nucleus. Where will the steroid receptors be? Where will be the steroid receptors? Answer, please. You have it in the cell wall or in the nucleus. Usually, am I audible?
Nucleus.
Okay. Usually, yeah, exactly. It will be in the story, it will be in the nucleus. So it will take time for the steroids to act. It is not like it will act like a magic. It will take time for the steroids to go inside the cell membrane and then inside the nuclear membrane and act. Okay, it will take time. If it's a life-threatening situation, along with all these things, you had some hypertrophium bromide also. If it's life-threatening, you have this hypertrophium bromide also. You will add. It will add to the bronchodilatory effect. Along with that, magnesium sulfate can be done. All these are smooth muscle relaxant. So it will help in relieving the spasm of the smooth muscles and plus or minus mechanical ventilation. Right? I got a message from Robin saying that you're going fast. You fast am I going fast? I thought I myself feeling sleepy because I'm going too much slow. Am I going fast? Hey, man, please reply.
Yes, ma'am, little bit faster.
Little bit fast. If I go slower than this, it will be too much sleepy for you. You people will sleep off. Anyway, okay, I go slow. But don't sleep off, okay, if I go slow. Chronic obstructive disease, I already told you it is irreversible. You will not have a reversibility with any of the beta agonists. The criteria for this diagnostic criteria will be FEV1 by FVC will be less than 0.7. Okay. Post bronchodilatate also the obstruction will not be relieved and you will have an X-ray finding of an hyperinflated lung. You guys had your medicine main class, right? Did you people have your medicine main class? The regular
Yes, ma'am.
session?
Yes, ma'am.
Okay, then it's okay. And of course, COPD patients will have a history of chronic smoking that comes up. How would you treat COPD as such? If it's an acute COPD, first thing you give some bronchodilators along with nebulizer. In the form of a nebulizer, you give some bronchodilators, salbutamol, and ipratropium. Then you give some steroids, hydrocortisone movie. Third thing, oxygen. Fourth, you give some antibiotic if it's infected. Fifth is the mucolytics to break down the mucus and bring it out. And sixth is the chest physiotherapy to bring out the secretions. The problem is the secretions in COPD. It will get secreted, obstruct one part of the bronchus, and thereby, after obstruction, more bacteria will grow there, and thereby the complete consolidation can happen. So the main purpose of treatment should be the removal of the mucus content from that particular area. If these things are not working, you give some aminophylline infusion. If that is also not working, then you go for an NIV or an intubation and then proceed. Okay. If it's a stable COPD, of course, you have to properly protect them from all the infections, and along with the short-acting and long-acting beta agonist, you proceed for a continuous treatment for that patient. Then, what is an obstructive lung disease and what is a restrictive lung disease? Obstructive lung disease, it is usually the problem is there is a reduction in airflow. The problem is in the airways. Whereas restrictive lung disease, the problem is in the lungs itself, lung parenchyma. Problem is with the lung parenchyma. Examples of an obstructive lung disease is the bronchial asthma, COPD, emphysema. Whereas interstitial lung disease is an example of restrictive lung disease. Other than that, the sarcoidosis. All these things are examples of restrictive lung disease. Bronchiectasis is an example of obstructive lung disease because it is a problem of the airway. Right? In this, you have to know a few points about emphysema because of its types. This emphysema has many types like century acinar, pan acinar, distal acinar, and irregular. In century acinar, this is the most common type where you have the emphysema of the upper lobe. Upper lobe is the most commonly involved area where you have emphysema of the particular bronchi. Upper lobe is involved in century acinar, and there will be alveolar sparing. In pan acinar, all the entire bronchiole will be having this irreversible dilatation of the bronchial valves. And this pan acinar usually seen in the lower lobe, and the pathology would be alpha-1 antitrypsin deficiency. Distal acinar, usually the proximal ones will be normal. The one which is distal will be emphysematous. Okay, this is usually adjacent to the pleura. Maximum involvement of the alveoli, and most commonly seen in the smokers. It occurs in the whole lung, and the pleura. Right? Irregular pattern will be, of course, irregular, and it is usually associated with scarring. Irregular will be most commonly associated with scarring. So this is the different types of emphysema. Then coming to a few types of pneumonias, you have community acquired pneumonia and hospital acquired pneumonia. Usually community acquired pneumonia, it will be less than 48 hours of hospitalization, you will have it. Hospital acquired pneumonia after 48 hours of hospitalization. And this is the most common type of pneumonia that is present. And the organism which is most commonly involved would be the Streptococcus pneumoniae, followed by the influenza, Haemophilus influenza. Whereas a hospital-acquired pneumonia is, of course, the nosocomial infection, and it is the most common nosocomial infection. Hospital-acquired pneumonia is the most common nosocomial infection. And the most common organism that is involved could be the gram-negative bacillus. Could be gram-negative bacillus more than the Staph aureus. Okay, this is what is regarding the community-acquired and hospital-acquired pneumonia. In community-acquired pneumonia, you have two types, typical and atypical pneumonia. Typical will be airspace pneumonia, where you have an extracellular organism which is causing the problem. Then predominant alveolar exudates will be present. Consolidation will be present. Right? And the treatment will be penicillin and penicillin groups. In case of an atypical pneumonia, it is basically an interstitial type, interstitial pneumonia. And it happens because of the intracellular. Remember, interstitial, intracellular organism, and there is no exudates. And the patient will present with a dry cough, and the treatment usually includes macrolides, doxycycline, clarithromycin. Okay, macrolides, doxycycline, and clarithromycin. So this is what is regarding the community-acquired pneumonia. Then in respiratory system, you have to know about this organism, which is very, very important to us, that is the TB. TB can be primary TB, primary pulmonary TB. In that, you have to know about Gons complex. What is a Gons complex? It is usually a subpleural lesion. The lesion is a subpleural lesion that is present along with the draining lymphatics and the lymph nodes. That is a Gons complex. In the chest X-ray, it will appear as a calcification. Usually, the fate of a primary tuberculosis, either it will progress and grow into a caseous disseminated disease to the other part of the lung, or it will become a miliary tuberculosis. If it's a lung, if it occupies this area, it is a progression to one part of the lung. Miliary means it will progress to different parts in a dot pattern like this, or else it will progress to a healed lesion, but it gets activated whenever there is a reduced immune system in the body. This becomes the secondary TB. So secondary TB, it is because of the pre-infection. Reactivation happens when the immune system is depressed at any point of time in their life, or else reinfection, if it happens with another another inoculum of bacteria, that time reinfection happens. In this patients, there will be Simon focus that is present in the apex of the right lobe, and cavitation will also be present. The fate of secondary tuberculosis, it can go for a fibrocaseous tuberculosis or biliary tuberculosis, or it can proceed with the entire lung involved, becoming a secondary tuberculosis agent. What are the other TBs, that is extrapulmonary TB, that you know of? The most common extrapulmonary site would be the lymph nodes. Okay. And then if the eyes are involved in extrapulmonary TB, you call it as flectanular involvement. Flectanular involvement. Flectanular keratitis means it is involvement of because of TB. If the involvement is with the kidney, you call it as putty kidney. If it's in the ear, there will be multiple penetration of tympanic membrane. It's very important. Multiple penetrations, perforations. It's very important. Tympanic membrane means there will be multiple perforations here and there. Okay. Then in the heart, it can be constructive pericarditis. In CNS, it could present as TB meningitis. So this is what is regarding the TB that you have to know of. Make sure you read the TB treatment from a proper protocol that you have, when they discuss the medicine in detail in the starting, right? So that time read that HRZD, proper recent protocol. Even in this, we call a PSN, they would have discussed